Okay, let's get her. We'll give her some privacy. Guys, I don't know what that camera's doing, but look, it's like.
It's looking for you. Once you stand up here, it'll follow you.
Oh!
What did that video say? Scanning for Mexicans.
There you go. The Eric Cartman.
Yeah.
Alright, anyway, sorry.
I don't think you're recording still.
Oh no, let me get let me get on here. Just so I don't show the test on accident.
Hey. Whoa. Yep.
To the cloud, right?
Yeah.
All right, good morning, everybody.
Good morning.
I can't believe we're already on respiratory. That is insane. It's my favorite because it means that we're getting close to being done, but not really, huh? How many more weeks do we have?
8 more. Oh my god. 55 days.
So that means we're halfway, right? Isn't it 16 weeks? Oh, I'm gonna jack this camera up. It's gonna break. Okay, guys, so I'm gonna do a lecture a little bit different today. I got a little bit of feedback. You guys gotta give us feedback, or me, well, yeah, us. But I think I'm one of the only instructors that don't really use the PowerPoint, and I know that like I spaz out and like, hey, remember this? Don't forget this. And so we're gonna use a PowerPoint. It's gonna be boring, than usual, but hopefully that will help you guys, or some more of you guys, understand the content. Okay. So respiratory is one of my favorites. It's the only time I kind of sort of get to flex my ICU brain, because otherwise, you know, like I'm talking about staffing. Let me see who can. Did somebody jump on? It's talking about non-ICU.
No, it's
Damn. Any level
You're gonna get
Mute it.
You're gonna get John. Okay, so a little disclaimer. I think I have all of you guys are traditional, yeah? For the most part. -2, but the rest of you APs. I don't have APs here, right?
Yeah,
Traditional students, meaning that you guys took nursing 11 and 12. Right? Yeah, okay. The reason I asked is because I have to change it up a little bit with them. Just because some of them haven't had that whole ABG breakdown and stuff you guys all have, so we're going to take it from there, okay? And then their lecture I'll record as well. If you don't remember how to do the ABGs, I do them like simple, like I don't use like Rome and this and that and tic-tac-toe. I don't use, that's too like I refuse to learn. I can show you guys the easiest way I do it, and you know I get the right answer every time. So with respiratory, I have it. I'm taking it for granted that you guys all have that basic foundation from as far back as biology, your cations, anions, your acid-base balances. You guys remember the hypotonic, hypertonic, all of that stuff. Okay. So I'm going to go through the lecture. If you have questions, please ask. We can get super deep into every single subject that we're going to talk about, and I can go like molecular level and stuff, but there's no need. Okay, at this point there's no need. I just need you guys to understand the concept. Okay, that we're going to talk about 4 or 5, I think, big concepts, if you will. So what I would suggest, if you want, if it works for you, write down that concept. Remember how I kind of sort of started doing that that concept map? Write it down in the middle, and then branch out and talk about it and understand it. But I'll tell you, okay, the next concept we're going to talk about is this. Okay, we're going to make it as easy as possible, but just know that behind everything that we talk about, like if anybody saw that YouTube video, you can get super deep, and that's how I get my jollies, like cations and anions and the acid-base balance and all that stuff. But we won't go that deep. I'm gonna make it so that you have the foundation, because later on you're gonna use it. okay? This is one of the only tests that I have that will ask you about concepts. And you'll see what I mean in just a little bit. Normally, I've been talking about this whole time about what would the nurse do? Well, really, what would you do with an anion gap? Nothing, okay? Because we're not providers. But you guys need to know what the concept is, okay? For example, what would you do with a low potassium? Realistically, nothing, right? Because you can't write orders, okay? But you have the knowledge that, you know, if your potassium is super high, you might have, you know, this and that, or if your potassium is super low, you might, whatever. You have the concept down. These are all a bunch of concepts. What are you gonna do with the ABG? Really? Kind of, sort of nothing, but you're gonna do a lot with it. And we'll talk about it because we have RTs that help us. We have different providers that are gonna help us. But as a team, guys, if you don't know what you're talking about, like just get out. You know what I mean? Like fly on the wall does a better job than you do. Does that make sense? I'm not trying to be mean, but you have to know these concepts. If you don't know what potassium is for, and that your potassium's low and your mag might be low, and you know, like, what's the point of being an RN? Okay, does that make sense? I hope that you'll see what I'm talking about. And I'm not trying to be mean or anything. I'm just saying, like, you guys have to know these concepts. Chapter 13. This was the old book, guys. So I'll update that. But I really strongly suggest you guys review your AVGs. I got feedback. I thought I was making it a little bit easier by not did I hit record?
It's
I
recording.
did. Okay. I thought I made it a little bit easier by not requiring you guys to do the AVG sheet and turn it in. But I was told that you guys want to do the AVG sheet and turn it in. That's totally cool. So I didn't make it part of the passport. So if you didn't do it, I mean, there's gonna be test questions, like straight up AVG questions, okay? So if you wanna do it, do it. If you don't wanna do it, you know, it's up to you, but I'm telling you right now, there'll be AVG questions on there. Normally I require it, but I try to make it as easy as I could for you guys. But just know that there will be AVG questions on there, okay? Let's see. And then the oxygen transport, oxygen delivery, real simple stuff. Like you guys will, it just like joke simple, okay? You guys will know what I'm talking about in just a second. So this is the first concept. This is the base axis, okay? So if we review, if we think about what we have, what we've talked about in the past with AVGs, you have, if you will, let's break it down easy, right? Or simple. You have the metabolic system, and you have the respiratory system, right? Mm-hmm. And so the respiratory system is controlled by what? The lungs, okay? That's where we get our ABGs, the CO2, you know, breathing fast, breathing slow, whatever. Now for the metabolic side, what controls that side?
Renal.
The kidneys, the kidneys, okay? Mainly the kidneys. The kidneys can do a few things. The kidneys can produce bicarb, and without getting into the whole chemistry behind it, like, you know, it's what's bicarb? What's the HCO3, right? Without getting too deep into it, you know, you have hydrogen ions and cation. Well, you have hydrogen ions, and then you have some cations in there. By the way, what's a cation and what's an anion? What's a cation?
Positive.
Positive. Okay, so I said it backwards. Sorry. And what's an anion?
Negative.
Okay, negative. Okay, so a base excess is just normally it's just like your kidneys pumping out base, if you will. Let's keep it simple, right? Usually I don't start with this base excess stuff. I'm spazzing out, and I think I make sense. But base excess is your kidneys pumping out base, if you will. So normal base excess is 0, plus or minus 2. Okay, that's your range. So if you have a base excess of, let's say, 10, okay, what are your kidneys doing?
They're working. They're trying to
Maybe compensated, pumping out a bunch of base, a bunch of bicarb, right? HCO3, yeah. So if it's a negative, like -6, is it pumping anything out? No, okay? Now, remember, we're talking about the metabolic side. So On that metabolic side also, we said what's a positive? A cation or an anion?
Cat.
Okay, cation. So our body has a bunch of cations. Okay, what are some cations?
Potassium.
Potassium.
The main ones: potassium.
Hydrogen.
What else?
Hydrogen.
Hydrogen. Okay.
Sodium.
What else? Sodium. Okay, write those down. Sodium, potassium, and what do we say? And hydrogen. Those are our three big ones. So, just so you know, if the patient is in a state of, let me think for a second, metabolic acidosis, one of the things that the body's gonna do, the kidneys in a normally functioning person, is that it's gonna pump out some bicarb, right? You guys agree?
Okay.
Also, just so you know, sodium is one of the largest quantity of cations in our body. So what is it gonna? What are our kidneys gonna do if we're like super acidotic?
It's gonna start creating. It's gonna start pumping out more.
You're gonna pee it out.
Yeah.
Does that make sense? Sodium, we're gonna pee it out. You guys follow? See, I feel like I'm so boring this way.
If it's no, it makes if it's
Okay. I want to jump around and talk. Okay. So going with that, let's think of our disease processes. And by the way, here I go. By the way, when we talk about this acid-base balance, I want you guys to think about disease processes, and I'll expand on that right now. So, if a patient is in a metabolic acidosis state, what do we say? We're gonna pee a whole bunch out, right? Tell me what happens in a patient that is in diabetic ketoacidosis. Is that a metabolic acidotic state?
Yes.
What do they do? What's one of the things that they're always doing? Polyuria. Okay, you guys catch that? Polyuria. Just so you know, the treatment, one of the big things that we do for these diabetic ketoacidotic patients is we hydrate the life back into them. We give them like 8, don't write this down, but I'm just telling you, we give them like 8 to 10 liters. Why? Because they've been peeing out all of this urine, right? They spill out all these ketones and pee. Does that make sense? Okay. So, again, it's 0 plus or minus 2. That being the case, sometimes what in our ABG, what represents in those 3, 4, 5 numbers in there, or values, what represents the metabolic side in our ABGs?
the HCO.
The bicarb, right? The what do we call it?
HCO.
The HCO3. Okay. Normally, the HCO3 is this. I don't want to say the same, but it follows the base excess. So if one day you see a problem without an HCO3, but they give you the base excess, it's the same thing. Does that make sense? And we have a problem in here that doesn't give you the HCO3, but it gives you the base excess. So we can determine, yes.
I did have a question about the case study that regards
The last one?
Yeah. So
We'll talk about that.
Okay.
Yeah. I like the way you think. And on that note, just to review, okay? I'm gonna act out because I'm kind of bored up here. Okay, am I respiratory acidosis or alkalosis? Acidosis. Okay. If I had a big needle in my arm right here, respiratory acidosis or alkalosis?
Acidosis.
Acidosis. Don't forget that. Okay? Think of that guy, that poor person, patient, whatever, that overdosed. Okay? And this will come back in just a second. Think of that overdosed patient and what they look like. They're on the floor. Are they? No, they're on the floor. Right? They're like, okay? And the patient, like, I have competencies. What state am I in? Okay, don't forget that. Okay, don't forget that. Think drug guy or think competency guy. Okay, let me make sure. Just so you know, guys, since I'm following this boringness, Usually, our cations are paired up with anions. Remember that, like there are pluses and a minus. Okay, so that's gonna play a role in what we talk about in just a second. Any questions on base axis? Now, let's think of our patients that have kidney problems. Okay, so from here on out, even in nursing 22, you have to, well, since you've been doing, right, since the beginning, since whatever, you have to look at the patient as a whole. Like if the patient has no kidneys because of end-stage renal disease, that they're on dialysis or whatever, is their acid base gonna be as what's the word I'm looking for? Reactive. I can't think of another word right now. As a normal person, obviously they're gonna be behind. They're gonna be like, say, a patient in end-stage kidney disease. What acid-base balance would they usually probably be in before dialysis?
Acidotic.
Yeah, they're gonna be acidotic. Okay. Now, for my test questions or the test, and in NCLEX and all that from here on out, you gotta think: is this patient? You gotta think what acid-base balance would they be in? Okay, and we'll talk about it in just like as we progress into the lecture. Any questions? So these are examples. I won't go through these, right? But remember, what's your normal pH? 745 to 735 to 745, and then your CO2 35 to 45. Remember these basic values. Just to review, guys, and just to, if you didn't know, we'll talk about it. The range is 735 to 745. Okay, that's the range. What's perfect?
740.
740. Okay, if you didn't know that or whatever, write that down. Perfect is 740. In the CO2, perfect is 40, and in the bicarb, perfect is what?
24.
24, because it's plus or minus 2. Okay, so if you have, when you go into your compensated, uncompensated, remember that. So if you're in the compensated, right, pH, which would be between 735 and 745. If you're trying to figure out what direction they're in, 740 is perfect. So if they're 741, would they be acidotic or alkalotic?
Alkalotic.
Perfect. Does that make sense? Okay. Let me make sure. So pretty much everything that we were talking about, the kidneys, the base axis here of positive 11, it's telling you that, hey, this person is trying to compensate. The kidneys are trying to remove, like they're trying to balance that acid base. Now, if you look on this one, if they gave you this sample problem, it should not be a problem, right? Because what are we missing here? We're missing the bicarb, the HCO3. But not really, because they give it to you as a base excess, okay? So if one of the test questions pops up and you don't have that bicarb, it's not a big deal. You still have that base excess to work with. Does that make sense?
So as long as the base X is +1, we know that it's trying to compensate.
Exactly. Because perfect would be 0, and then that plus. But is it really compensated? Because remember, it's not.
It's
right?
trying.
Well, you can still see.
What would this be? Uncompensated or compensated?
Uncompensated.
Uncompensated, right? Because why? That pH
It's not
is still
normal.
out of whack. Okay? And if you guys don't remember that whole compensated, uncompensated, whatnot, I would tell you, because you have that test coming up, and I still have to lecture the other class, don't sweat it, but maybe at some point, if you guys remind me, like we'll get together real quick, because I want to get together with those AP folks to not leave them behind. You guys are more than welcome to come out and, like join in, okay? And then I can announce that sometime. I don't know when or what, and I'm sure somebody will miss it because of schedule. I'll make it on Zoom, whatever we have to do. Yeah.
I have Mrs. Ortega's respiratory video.
And if you have Mrs. Ortega's respiratory video and you pay the fee for copyright and stuff, then you guys are welcome, okay? And just send it to me, Venmo me.
For a small fee.
for small feet.
What's the fee?
You know what?
Ice
If
cold,
all of you
Diet
come
Coke.
in, I'll make it $5 a piece. So that's 100 of you guys, right? For 1 hour. Okay, so obviously you guys know that we have alterations in base, okay? For whatever reason. Usually I start off with what I'm gonna say, okay? So I want you guys in general to make it as easy as possible to think if generally, okay, there's always like an exception, right? If somebody or something inside is dying, okay, kind of rough, right? If the person is dying or the kidneys are dying or something inside is dying, what, I can't say acid base, but would they be acidotic or alkalotic? Acidotic, okay? Just a general idea. Let's think about it. When you're, not you, but when something is dying, they're not able to oxygenate, you know, it's everything's like you have like apoptosis happening inside and like stuff is dying and stuff, when it's dying, it releases hydrogen ions and like, you know, you have an acidic state, okay? And we'll talk about how we get into a metabolic alkalotic state or respiratory, you guys can already imagine. But in general, guys, over the years is looking at studies and videos and lectures and everything, the simplest way I can think of is to tell you guys, or to lecture you guys, if something is dying, it's probably acidotic. Probably meaning there's always some special something like something, right? But probably acidotic. Natural, like in nature, probably acidotic, okay? And we'll touch on that in just a second. Now, alterations in base, sometimes when we have some instances or some situations that we can have where we become alkalotic, or for example down here, we start throwing up a bunch of that acid juice, right? That acidic content, the stomach content. We start just excessively throwing it up. And if you don't have that acid content in your stomach, you know, remember that negative feedback is gonna say, hey, pump more acid out. And it's gonna keep trying to use all these hydrogen ions and it's gonna try to catch up. We have gastric suction. We keep pulling all that acid out of that patient's stomach. That stomach is going to keep trying to create more. We have bicarbonate IV resuscitation that, you know, the patient, for whatever reason, we decided that that patient needs a bunch of bicarb. Now we're in that altered base state, okay? Questions, guys? Diarrhea, and I won't give you the answer. Can that cause acidosis or alkalosis?
Alkalosis.
Acid out.
Alkalosis.
I'll leave you guys that for homework, okay?
Your acid goes down.
Okay, so far we're okay, yeah? Everyone's okay? All right, this should all be easy for you guys. Sample problems, I'll leave that to you. Okay, that was our first concept. Now we're moving on to the second concept, okay? Anion gap. All the anion gap is, let me think for a second. It's just, guys, anion gap is just a tool. Okay, let me backtrack. You know how we have the cations and the anions, right? We have to have, our body likes homeostasis. I'm just throwing it out there. It doesn't, like, don't write this down, but you have to have 5 guys and 5 girls, okay? I know we have like in-betweenies and, you know, we love them and all, you know, everything's good. But for the most part, we have 5 girls, 5 guys. The women will be the negative ones. Not because of anything. Watch out, man. I'm just kidding. Fine, the guys are the negative ones. But you have 5 women and 5 men, okay? 5 positives, 5 negatives. Within those negatives, we have oh my God, do we have chlorine? Is it chlorine?
Yeah.
Chlorine? What else do we have?
Calcium?
Bicarb, right? So we have a bunch of negatives, and those negatives are going to be in balance with the positives. Okay? Does that make sense? So you cannot have just a bunch of hydrogen ions, right? Is hydrogen a plus or a minus?
Plus.
Okay, you cannot have a bunch of pluses in your body because the negatives, like, it just doesn't work. We have to be in a balance. Our body is always trying to always be in a balance. Does that make sense? The anion gap, guys, all it's doing, it's telling you this is your positive negative range and whether or not you're out of range. Okay? So I think I might, okay, so here the normal one is 8 to 14. We're gonna use that 8 to 14 number because some books say like up to 16, and I'll tell you why it's different. Let's go through each one of these. The anion gap, 8 to 14, and all we use the anion gap for is to identify imbalances during different disease processes. One of the biggest ones that we see is, again, going back to that diabetic ketoacidosis. That diabetic ketoacidotic patient, let's think back real quick. What happens? I don't know if I should draw this on the board, but I'll draw it on the board. Let me see, screen control. Let's go. All right, guys. Usually, we have. Because I'm trying not to give you so much information because you can get so deep into this. Usually, the anion gap is in that diabetic ketoacidotic patient is big. It's wide. It's like in the 30s, 25, 30. When it's normally up to, like, let's call it 14. Why does that happen? Well, because that patient is trying to, that glucose molecule is taking over, and it's, what does glucose do to our cell as far as potassium? It what? It kicks it out of the cell, right? And so, I don't know, this is not going to be on the test, okay? So this is what happens. You have a cell, okay? We have H's and potassiums, hydrogen, okay? So we have, let's say, a proper number of hydrogen ions and potassiums and everything's balanced. What happens in a diabetic ketoacidotic patient is that they become super acidic, okay? Very acidic, more acidic, and so I don't have to write H's, I'm just gonna put dots. And all these dots all over the place into the vascular space, right? So then the body can't hold that many, so what does it do? It starts pushing them out. Like, it's just too many. So what it does is it starts pushing them into the cell. Okay, so now you have more intracellular, and then what happens to a potassium? The potassium gets pumped out of the cell, so then the K is blue, so then it starts coming up in here, okay? So now your potassium levels are super high in that patient, okay? So they switch around, and so what happens is that patient starts to pee out. They're in a state of hyperkalemia, and everything's out of whack. Because we don't have that much, the body's trying to compensate by breathing fast, by peeing, it's doing everything that it can, but it just cannot keep up with that glucose, the amount of glucose of like 700. Okay, so what does the body do? Like we said, it starts breathing faster. What is that going to try to compensate for? Or what's breathing faster going to do? It's going to blow off CO2. We're going to try to become alkalotic, right? And then what is peeing a whole bunch going to do? Remember, we have sodium and then we have sodium, right? And then without talking about how it combines with sodium, what is the sodium? We're going to pee it out. So anion gap, guys, is just telling you that there's a big discrepancy between the pluses and the minuses. Okay, so this person's anion gap, instead of being 14, it'll be like 27. I'm just throwing a random number out there. It's just a tool to let you guys know that, hey, your anion gap is super wide, your anions and your cations are out of whack, and that's all. I hope I didn't lose some of you guys. Long story short, it's just a tool, guys. So then what we do is we start treating that patient, we start treating them with fluids, with insulin. So the insulin does a few things. We're trying to drop that person's glucose level, and we're trying to push that potassium back in, and we're giving them fluids to hydrate them so that we can water down, this whole mess. So then what we do is we take the anion gap, and let's say today we start at, anion gap of 27, but tomorrow the anion gap is back to 14, and what would it look like? It would go back to homeostasis, like, potassium. And so what we do is our therapy is driven by the anion gap, okay? Other instances where our anion gap goes through the roof are when patient, if you will, does something to harm themselves. For example, I don't know if I have the cell, or the slide, but it says cat mud piles. Is it in there?
Yeah, it was.
Let me look. Is it in here? No, it's not in here. Okay, I'll put one up in just a second. But the things that cause your anion gap to go high are things that kill a organ in your body. So for example,
Alcohol use.
maybe like an excessive amount of alcohol, like excessive, like trying to kill yourself excessive, okay? Like an overdose. But usually a lot of times we see Tylenol. Patient wants to overdose on Tylenol. What body part is that gonna try to kill?
Liver.
Your liver. So the liver is you're gonna see your anion gap going up because of that. And let me show you guys while this thing comes up. So we say, right here. And I'm sorry guys, I thought I had a, is this coming back on? A slide on here. I must have taken it out at some point. But I want you guys to get as smart as possible about this stuff so you have an idea.
It's in one of the readings.
Okay, cool. In the chapter?
The basic interpretation. Yeah.
Oh, the mud pile thing?
Yeah.
Oh, perfect. If you guys look at that, what are some things that cause an increase in your anion gap?
Diabetic, alcoholic, more starvation, ketoacidosis, lactic acidosis.
Salicylates, yeah. So if you look at that list, guys, there are things that too much of, they're kind of sort of trying to kill the body, if you will. Right? Like an overdose of salicylates, an overdose of like maybe a state of uremia. Where will we see uremia? A person that doesn't have those kidneys that function, right? What is uremia? Uremia. Somebody Google that. What is uremia? You're gonna learn something new today.
Uric acid.
Not uric acid. Urea where?
In the
Why
blood.
is this thing? Huh?
In the blood.
In the blood? So what's uremia? Urea in the blood, right? Yeah, urea in the blood. I don't know why this thing's not turning on, guys. Sorry. Oh man. We broke it. So that's what your anion gap is. Does it make sense?
So
Yes.
basically it's anion gap will just tell us if there's abnormalities in electrolytes. So
Pretty
if
much.
it's normal, then that's not because of the electrolyte.
Pretty much.
Okay.
All of that talking I did, yeah, that's all it does. Okay? But I want you guys to understand like the fundamentals behind it, okay? It's another tool that we use to, and this is what I was gonna show you, but diabetic ketoacidosis, some of these are poisons like paraldehyde, and I can't even pronounce some of these words, but pretty much it's something that's gonna cause a state of acidosis in your body, and it's gonna increase the amount of hydrogen ions, and it's gonna just send your whole body out of homeostasis. That's what anion gap is. And to further solidify this, There's usually two formulas. I don't know if I have one or two. Just one here. There's usually two formulas, okay? And to calculate the anion gap. And what it does, remember your parentheses, you do these in mathematics first, and then you take this minus this or whatever. But you're looking at the sodium, and you subtract it from your base stuff, right? Your negatives, which is your chloride and your bicarb. And that equals your anion gap. And your book sometimes has a potassium one in there. Why would potassium go on this side or this side?
On the left side.
Right.
The left side, this side?
Yeah.
Yes, perfect. Why would it be on that side? Because you have your sodium and your potassiums. Are they positives or negatives? Positives minus your negatives. Okay, if you will, your guys versus your gals, right? Your pluses minus your negatives. That's all it is. And it's just a tool that you guys will use later on to help with your diagnosis and treatment of different patient populations. Yes?
Why is the potassium not on that formula?
It's just a different formula.
Okay.
That's why, remember I told you on this formula, I think the highest it'll go is, I don't know if we said 14, and the other one might go 16. That's where you have the difference. Which one do we use? It just depends on the facility. And you know what, guys? I will use this formula here. This, not the one with potassium. Just to throw an easy question for you guys to like knock out. Okay?
Because there's more sodium than potassium.
No problem. And then here's an example. So, you know, when you study, just punch in some numbers. Make sure you know how to get them consistently every time. Cool? Let's see.
Wait.
Yes.
For the bicarb, do we get that from the ABG, or is there like a blood, like CB or CMP lab value?
ABG.
ABG. So.
Yeah. No. I take it back. It's a lab value. If you look at, I'm going crazy right now. If you look at your lab values, and I'll post them up in just a second. If you look at your lab values, it has CO2, it has bicarb, it has what's in the blood. So it's not your ABG.
Okay.
No, it's not your ABG.
I've always wondered that.
Yeah, no. And then I don't think there's anything else. Now, if you go through this one, everybody, you guys should all be able to go through each one and like break it down as far as your sodium, your anion gap, all that stuff. And then see here it says labs, your sodium, chloride, and your bicarb. So it's different than the ABGs. Questions? I just realized I forgot my props, damn it. Yeah.
In the book, for the formula, without potassium, the normal range is 8 to 12 MEQs. So do we want to go with what the book says?
We're going with what the book says. If the book says, and let me tell you, I'm not gonna like nickel and dime you guys, or is it like 12.5? No. It'll be like something off, okay? Because usually when those folks are sick, they're sick, and it's a big number. Yes?
So it's not 8 to 14? Like
No,
this
he's saying, whatever the book says, he's saying yeah, okay?
So it's 8 to 12, not 8 to 14?
Yeah. Remember, guys, that every facility is gonna be different. Because if you think about it, every facility is going to use different normal, bicarb values, normal magnesium values, right? Normal potassium values. Potassium across the street might be 3.5 to 5. If you're in a cardiac unit, it's going to be 4 to 5. Okay, so that's why it fluctuates. Guys, I need my props, so let's go ahead and take a break real quick. Okay, what do you guys need? Like 10 minutes? Okay, let's do a quick 10 minutes. Any questions before we go start? No? Easy stuff.
Are you going to post the answers that the president for them? We can check if they're correct.
Fusion stuff. I actually wanted to say a few things. When you guys are studying, I want you guys to just take a handful of disease processes, okay? And then just think them through. What would that patient look like? Because I'm gonna ask you that. I can't ask, well, I'm gonna ask you that. So it's gonna be something like, patient overdosed on whatever, on, let's say, narcotic. What acid-base balance would they be in?
That's dope.
Okay, a patient has nonstop Well, elderly patient, not coherent, GCS of like 13. They've been on low wall suction through the NG2 for the last 3 weeks. And she's on whatever. What might they look like? Alkalosis, okay? What about a patient, like right now, you're the nurse, whatever, and that patient has throws a PE. What are they gonna look like?
Alkalosis.
Alkalosis.
Respiratory.
Alkalosis.
No, alkalosis. Yeah,
They're
alkalosis.
retaining the
But then
CO2.
acidosis.
Okay, so that's a good one, right? That's how I'm gonna trick you guys. But if you think about it, I threw a PE. Am I gonna be like this? No, right? You're gonna be initially, right? That alkalosis, just like a patient in an asthma attack. We are quick to jump to that conclusion. Oh, respiratory acidosis, which is we'll get there. Excuse me, but initially that person, I can't breathe. Right? And so they're gonna be trying to compensate. Now it's an ominous, hugely ominous thing when that asthmatic starts doing one of these. That patient's about to do what on you? Right? You see the difference? So you have to think about it for a little bit. So when you're going through your stuff, don't jump to that conclusion. Think about it for a second. Think to yourself, is that patient gonna look like the person that's about to take what do you call it, a competency test? Or are they gonna look, I keep saying that, I'm gonna get beat up. Or is that patient gonna look like, drug dude on the floor? Drug dude on the floor is gonna be, that acid, state, that respiratory acidosis, okay? Questions? Now let's talk about that mixed acidosis. Mixed acidosis, right? I don't have the thing in front of me, but from what I saw real quick right now, it's gonna be a mixed acidosis. The respiratory system and the bicarb system are both acidotic. Okay? What other state, one word, right? What other state would you see that in?
Code.
A code. Death. Okay? Let's backtrack here. Normally, patient has respiratory failure. Okay? And they code because of respiratory failure for whatever reason. Like, or ARDS or whatever. Whatever disease you guys are gonna learn in 22, right? Respiratory. Okay? Initially, our body, or let's say, I was gonna go one direction. Let's go back to our code. That patient codes respiratory failure. Okay? We're doing chest compressions, we tube them, everything's good, we're trying to maintain, but that person was down for a little while. Okay? They were down for a little while. When our body's not working, when we're not oxygenating, what's happening to the rest of us? It's slowly dying.
Slowly dying.
Right? And so what's one of the first things that shuts down in our body? The kidneys. In the ICU, in case you guys didn't know this, and in general, post-op and just in general, we use urine output as one of the indicators of our fluid status. Fluid meaning like our volume, our blood, if you will. Fluid status, okay? So in case you haven't heard this before, listen and then write it down. Post-op, especially just anything post-op, we look at have you guys heard this before? No?
Yep.
Yeah? With the whole kidney fluid? Oh, okay. Usually post-op, this is something that you're gonna talk about ahead in 22. I thought maybe you guys already went over this. Normally, our body will shunt blood away from like the extremities in order to preserve itself. Okay, that's why your hands get so cold when it's freezing outside. Your body's like trying to preserve itself. Okay. In a state of like let's say a trauma, which we'll talk about if we get to it today. We'll start talking about it. In a state of trauma, you're losing a whole bunch of blood. So what the body does is it starts shutting unvital organs down or unvital stuff down. So it brings blood, it shunts blood to, to the core, if you will. One of the things that takes a hit are your kidneys. The kidneys flow, don't quote my numbers, but about 25% of blood at like any given time. That's a huge volume, amount of volume. So if your body is low on volume because of a trauma, or because post-op, or you're bleeding internally, we usually, as a nurse, we have a Foley in that person. We're looking at the urine output, because if there's no flow to the kidneys on a regular patient, your urine output is down. Okay, this is why it's so important to, as a nurse, we're always watching that urine output. Normal urine output, I forget what it is, guys. I'm kind of older in the what was taught to me, but before it was around 30 mLs an hour. Now it's like,
No, it's still.
oh, it is, because they went to a number. They went to like per kilos, per this, but I think 30 mLs an hour is what I learned. Okay, so whatever it is now, but 30 mLs an hour. What that means is your kidneys are getting perfused at any given time, and at the minimum, we're always putting out some kind of urine, unless we're like super dehydrated, right? We're putting some kind. So a patient, obese patient, after a Roux-en-Y surgery comes back, and you're watching the urine output. You notice the urine output is down. They started with a urine output of 40 an hour, and now you notice for the last 3 hours, it's been 10. What do you think is happening?
They're bleeding.
They're bleeding. They're bleeding. Does that make sense? Okay, and I'm so sorry we got off on a rant. Just so you know, kidneys, okay? So going back to our code, if our body is not, so when we go into respiratory failure, a lot of times our heart gives out, and our whole body starts to shut down. So what does it do? It shunts blood away from the non-vital stuff. One of the non-vital things that gets hit is what? The kidneys. Okay? So let's say that person's been in a code for, I don't know, maybe like an hour long. We've been pumping and pumping and pumping and pumping, and they're not, it's not working, and you intubate them, and finally we get that person back. That whole hour, guys, with that hypovolemic state, that hypoperfusion of that patient's system, they're not getting blood flow to the kidneys. So the kidneys got damaged, okay? Are they gonna be able to produce any bicarb? So this is how you start getting those mixed acidotic states, okay? Bam.
That makes sense.
Muy chingón.
That's it.
Okay, so that's how you get those mixed acidotic states. It's a state where your body is shutting down on both ends, if you will. Is that possible? Of course. Does it make sense? Does that make sense?
It does.
So initially, we had that whole ABG, and if this is this, then the other one has to be opposite. But that's not the way it works. Sometimes our body just cannot compensate for everything. Let's think about our patient in ESRD. They can't, produce that base, and let's say they go into a respiratory acidosis, which normally they are, right? They're driven by that higher CO2. So their respiratory acidosis, now they're a dialysis patient. Now they could be in a mixed acidosis state all the time. Does that make sense? Anybody have questions? Does that make sense? Now, to be in an opposite state, alkalosis, that's not. I would say I can't say it's impossible, right? Because somebody's gonna find something somewhere, some dude in like the middle of nowhere, like, oh yeah, whatever. But a mixed alkalotic state is probably a man-induced thing, like a medically induced thing, right? Because if something bad happens, we don't turn alkalotic, we turn acidotic. Does that make sense? Questions? I'm gonna do this to you guys, and I'm so sorry, but I'm gonna jump this ventilation perfusion. We're gonna come back to that because I'm gonna change the order of this. This is the next big topic, or the next concept, okay? I think this might be the last concept. Everything else is back to like normal, easy stuff. Yeah, this is the last concept. We're gonna talk about VQ mismatch, but that should be easy for you guys. So the last concept. You have what we call an oxyhemoglobin dissociation curve. I like saying that word because it's like the biggest word I know, and I look kind of sort of smart. Yeah, the the oxygen hemoglobin dissociation curve is probably going to, like, and then little do they know I'm dumb as hell. Okay. The oxygen hemoglobin dissociation curve, all it's saying is very simple. You can read into this and you can get into that curve, okay? All it's saying is a shift to the right, okay? A shift to the right, the affinity of oxygen is gonna be less. So if you're in an acidotic state, okay, your affinity, your ability to grab onto that oxygen is gonna be less. So for example, and this is not fault, I'm just making up numbers. If at a normal, see the black line, that's normal, right? So what that line is saying is that at 100% saturation, your PaO2, okay, by the way, that's what this is, your PaO2 is gonna be 100. If your oxygenation drops to 90%, your PaO2, and we're just making numbers up, okay? Your PaO2 is gonna be, I don't know, let's say like 80. Cool? At 90%, you're about PaO2 of 80, okay? And I don't know if it matches because I don't know if that's the scale. Does that make sense? Okay. So what it's saying is, it's a correlation of SaO2 correlates with the PaO2. Okay? Cool? Yes, okay. Now, what I'm saying is, if you're in an acidotic state, okay, acidotic state, like let's say that patient was in a code, let's say they were dying, whatever, fill in the blank, acidotic state, your saturation is 90%. If you're shifting to the right because you're acidotic, normally we say your PaO2 is going to be 80, but if you're shifted to the right, your PaO2 is going to be 65. Does that make sense? So the more acidotic you are, the less able you're able to hold on to oxygen. Okay? Give you an example.
So the verbiage is less acidotic to the right.
So long story short, and then we'll get into detail. When you're shifting to the right, the person, write this down, the person is hyperthermic, right, requiring more oxygen. They're in a metabolic state that requires more oxygen. Okay, maybe after exercise, they're in a lactic acidotic state. Or there's one more, what am I missing? Obviously, I said acidotic, higher temperature, yeah. Question, so we said if they're shifted to the right, you're more acidotic, your temperature might be higher, anything that requires more oxygen, okay? So now, let's give you an example. Have you guys walked into a room, in a patient's room, think of grandma, right? Grandma, you walk into grandma's room, she's sounding like 87, you walk in and, hey, my dear, how you doing? Blah, blah, blah. And she's cool, like no respiratory like problems or anything. Has anyone seen that? Like they're sounding 90% and like asymptomatic, they're chilling. Who has not seen that? Okay, so you can walk into rooms, they're sounding like 91, they're sounding 89 and they're chilling, like nothing's happening, all good, okay? Now, who's worked with COVID? Hold your hand up. With patients with COVID. Hold them up high. So not a lot of us. Okay. A patient with COVID, what happens, or what used to, well, is COVID still around? Anyways, what used to happen, what happens with COVID is that these patients, they would be satting 92. 92, 92 is not a big deal, right? 92. What did they look like? Like ready to die. Have you guys seen that? That hurts. I guess I'll do that. Have you guys seen that though? Who has not seen that? So just so you know, it's okay. Just so you know, these patients, they're barely satting 92, but they can't breathe. They're not able to breathe. Okay? Why? Because they're acidotic. Their oxyhemoglobin has shifted to what way? The right. So they're not able to hold on to oxygen as well, okay? So if we think back to those ABGs, you have your SaO2, your finger, and then you have your PaO2, right? remember how I explained to you the soda bottle with all the oxygen bubbles in there? Your PaO2. So what it's saying is that if you're acidotic, okay, your 2-liter bottle of soda, remember it has a whole bunch of bubbles in there? If you're acidotic, you're gonna have less bubbles, okay? Your ability to hold on to bubbles is gonna be less. Does that make sense? Yes.
So I had a patient at clinical and they were telling us, oh, we can't breathe, and they were doing accessory muscle breathing, but their pulse ox was staying like above like 92. So is that why?
92. That's why. That's part of why. That's part of why. Okay? Without seeing their X-ray and what else is happening, but that's part of why. Yes.
So the study measures how much oxygen is in the blood, but the PO2 is how much oxygen is in the tissue?
No.
Or no?
No. So the SaO2 measures. Remember, we have the hemoglobin. Every hemoglobin gets 4 molecules of oxygen. That's what it's measuring. The SaO2, right? Good, Khalil? Yeah. Okay. So we'll review after if you need. That's okay. But normally the PaO2 is all the blood. Like if I cut myself and the blood comes out, all that juice that comes out, that red stuff, that's what that PaO2 is referring to. How much oxygen is in the juice that comes out of me? Does that make sense? In the blood that comes out of me.
So if they're
Okay.
acidotic, there's less of that fizzing.
It's
Well,
gonna be harder to maintain
Oh.
that blood O2 in the blood. Yes.
So just to make sure I'm understanding this, so if a patient's acidotic, they're gonna have a shift to the right because they're unable, the ability to grab the O2 is less. An example would be a patient who's setting 90, but they're not chilling and they can't talk to you. And you also said they're they're in a hypothermic.
Hyper. Yeah, hyper. If I said hypo, I'm so sorry. Hyper, hot.
So a hyperthermic state, a metabolic state, and a lactic acid state?
Yeah.
Okay.
Yeah. So anything that'll increase your demand, anything that'll make you acidotic. Long story short, guys, if you didn't catch all I said, this is what you need to know. A shift to the right, bless you, you're gonna be acidotic. If that shift to the right is acidotic, a shift to the left, you're gonna be alkalotic. Okay? And I go into that extra detail for a lot of us are like, why? All of us are probably like, why? But that's what it comes down to. And there's videos and resources. But bottom line, a shift to the right, you're gonna be acidotic. A shift to the left, you're gonna be alkalotic. So, in a code blue, our person is gonna be acidotic. Okay? We get that person back. Have you guys ever heard that we sometimes put these patients in a hypo, in a cold state after code blue? Has anyone ever heard that? So sometimes what we do is we lower their temperature. Okay? Why?
Increase the affinity.
Yes. So I didn't hear what you said. What did you say?
Reduce oxygen demand.
Reduce oxygen demand, but
Make it hold on to it better.
yes and yes. So if we make a person, have you ever wondered why a person survives after they were frozen and like they thaw them out? Oh, I'm alive, you know, maybe a little bit dumber than you, but I'm alive, right? The decreased oxygen demand, but also a shift to the left, a lower temperature, a higher pH, meaning like pH of 7.6, right, etc. Lower CO2, a higher affinity of oxygen, meaning that a shift to the left, you're able to hold on to oxygen a little bit easier than a shift to the right in an acidotic state. Does that make sense? Bottom line, guys, if none of this makes sense, this is what you need to write down. Oxyhemoglobin dissociation curve, shift to the right, acidotic, lower pH, obviously higher CO2, right? And then higher temperature. A shift to the left, higher affinity to oxygen, lower temperature, higher pH, meaning like above, 7.45. Questions? And now the question that really matters, how in the hell or in the world am I going to use this information, right? It's one of those concepts, guys. What am I going to do with this as a nurse? It's one of those concepts that they might build on, or they build on in Nursing 22. And it's one of those ideas that, why when you guys get to the ICU, why is this patient not breathing? Why are they not, able to, we're giving them all this oxygen and we're about to go into the VQ mismatches. We're giving them all this oxygen and it's not working. Why? This is the foundation of why. Okay? Questions? All right. Easy stuff. Now let's go back up. And this this just shows the same thing. So pretty much, does anyone get it before I confuse anybody? Yeah. So at 90%, or let's say let's say 90%, if that patient is 90% SaO2, if that person is acidotic, what would you expect their PaO2 to be? Throw a number out there. Perfect. Something on the lower side. And then opposite to that, a person that's citing 90%, if they're shifted to the left, if it's cold or whatever, they're outside, I would expect their PaO2 to remain, maybe 80. Okay? Cool? And this is partly why some of the problems that, you have with all these disease processes happen, because they're in an acidotic state, stuff stops working, they can't even hang on to oxygen, etc. Let me see. Okay. Let's go back up to the VQ mismatch. VQ mismatch should be like review, right, to you guys? Let me see if I can. Well, I won't write it down. Okay, just for sakes of the lecture, okay? Don't quote me outside of this lecture, but just to give you guys maybe like a visual, maybe like something to think about and how it relates. You have the V and you have the Q. Okay, what does the V stand for?
Ventilation.
Ventilation. What does the Q stand for?
Perforation.
Just for the lecture, just to understand this stuff, our VQ mismatch, our VQ is normally 1/1. Okay, 1/1. And you guys have heard me say this before. 1/1. The V is 1, the Q is 1. That's normal. Now, so you have instances where what is the V? You could consider it what, your alveoli, right? Your what else? Like maybe alveoli. What else? Maybe atelectasis. Not working. Your lungs. And then the V is just the perfusion. Okay, the blood. Okay. When do we have problems with VQ mismatches? Any disease process you guys can think of? Okay, let's start with this PE. Okay, so remember, everything we talk about, if it's high or low VQ, is in relation to the V. The V is the king, the V is on top. If the V is big, then it's a high VQ. If the V is small, then it's a low VQ. Okay, well, anyways. Okay, so in PE, or hold on, let me show you my high-tech stuff, okay? Last week, this was your colon, I think?
Yeah.
Okay. This week, it's empty, okay? This week, this is your alveoli, and this is your blood flow. VQ is 1/1, okay? So if, let's say, a person is in an automobile accident, okay, and that's what they sound like when they're in an automobile accident. So, what VQ mismatch is this? Is it a high VQ or a low?
Low.
Low. Remember that this is the V, this is the Q. What is this called? This would be like atelectasis. Okay, does that make sense?
Mm-hmm.
So how do we fix this VQ mismatch? We have to get the alveoli up, maybe depending on how bad the trauma is, maybe a chest tube, maybe intubated, etc. Yeah? Okay. We throw a PE. This is normal, okay? We throw a PE, all right? Like, sad. Is this a high VQ or a low VQ?
High.
High, because remember the V is what we're talking about, okay? How do we fix this guy?
Remove the blockage.
You gotta remove the clot if it was that easy, yeah. The clot has to be removed, okay? Now, what about this guy? Is that high, low, silent?
101. Silent.
Silent. Yeah. How does this happen? Say it one more time.
Yeah.
Maybe a code. maybe that patient, that's a good one, maybe that patient had a PE and then they started coding, right? There's no lungs, so that's what it looks like. Or I think the book says,
What if they have like a hemothorax?
yeah, a tension pneumothorax. Let's talk about pneumothorax, tension pneumothorax. What happens is, do you guys remember pneumothorax? So the gunshot wound, right? That patient has no lung because the lung collapsed, okay? And then remember, I might lose some of you guys, but remember, if you have a hole in the chest, initially, what's our VQ mismatch if it's like this? If it's like this, it's a low VQ, okay? Right, I got shot in the lungs and I have a hole. Every time I take a breath, the air inside the wrong area gets bigger and bigger and bigger and bigger. And then eventually I'm gonna start pushing down on that pulmonary artery and those the great vessels, and it's gonna push and get bigger and push till you're like this, okay? And this is probably a code right here. And so what is the treatment options? If you guys get it, you just go ahead and go home. You guys are
Press a
badass.
needle in the center.
I'm just kidding.
Oh.
It would be a needle aspiration. So real quickly, we have to evacuate that wrong air out of that chest, okay? So as soon as we evacuate, and then the lung can inflate a little bit. Does that make sense? And I think we're going into trauma right now next. So that's what that VQ is. So I want you guys to, as a matter of fact, in the book, it has sections, I think, and it talks about the different disease processes, right? Does the book, anyone have the book? Can I see that picture? Oh yeah, that picture right there that Gabriel has. Can you show it? The one on the left, on the bottom?
Oh.
It has like the different, this is down, this is up.
What page is it on?
It's on the study guide.
Oh, but that goes through don't worry about it, it's okay. That goes through in that reading, it goes through and it tells you in this disease process, your VQ is this. So for example, let's think about, thank you, pneumonia, right? Do you guys have this picture in your book?
That's where it came out.
Okay, cool. So this is a picture I'm talking about. Thank you. Let's think about pneumonia. What's happening in the pneumonia? Let's first of all, what's the VQ on that? Low. Okay? And what's happening? We have junk and stuff in between. So, check it out, guys. Okay, this green marker represents boogers. Okay? Okay, this is normal, white, 1 to 1. But in a pneumonia, we have stuff in between an alveoli and your vascular space, or infiltrates, or whatever, right? And is it letting you get that, oxygen through? No. So what do you gotta do? You gotta fix that pneumonia. Does that make sense? So whenever you guys study, pick a few disease processes and say, okay, in a trauma, atelectasis, what's the VQ? Okay, bless you. In PE, what's the VQ? In whatever said disease, what's the VQ? Okay, there's only like a handful of diseases we can talk about. And the book lists 6 or 8 of them. That's what I want you guys to know. Questions? Easy stuff. Yeah? Let's see. So see, here's some cases. What causes VQ mismatch? Fibrosis. Okay, let's look at fibrosis. Would that fibrosis be a high or a low VQ mismatch?
Low.
What do you guys think? High or low?
Low.
What's fibrosis? The lungs, they're stiff, they're no good. So high or low?
Low.
High or low? Or medium? High or low? Huh? Low. Right? Because the V is down. The V is not performing. It's not the 1. Maybe it's like a 0.7 or whatever, but we call it a low VQ mismatch. Does that make sense? Because it's a V, it's a ventilation problem. If you think of fibrosis as me putting a bunch of saran wrap around my chest, okay, and taking a deep breath, can't breathe. Can't breathe. It's a ventilation problem. Does that make sense? Okay. And then PE, we talked about that one. Pulmonary hypertension. Is that a high or a low VQ?
Hi.
It's a vascular problem.
Well, is it a vascular problem or is it a lung problem?
Oh, pulmonary.
It's an inside lung problem,
Yeah.
right? Or a vascular problem, yeah. So it'd be high.
Yeah.
Does that make sense, guys? And then if we go down the list, pneumonia, is that a lung problem? Is that a ventilation problem or perfusion problem?
Perfusion.
Pneumothorax? High or low? Huh?
Silent.
Initially, pneumothorax.
Initially, no.
Low or high?
Low.
You know, guys, so let's differentiate that right now. Unless I say attention pneumothorax, we're gonna call it, you know, just a regular atelectasis, okay? Because you don't know what stage that, because it could be both. You don't know what stage, and I'm glad you guys are thinking that way. It could be like, you know, that if it's early on after the accident, yeah, it could be a low VQ. But if it's after a while, it could be like a silent unit. Does that make sense?
So initially it's
unless
not-
it says attention pneumo, we're just gonna call it, you know, a low.
Low.
Cool. That way we differentiate, but I want you guys to understand what can happen in between. You could be like, you know, kind of both. And then knowing this information, guys, as a medical team, right, we just reverse the problem. So if they have pneumonia, we get rid of that junk that's in there. You know, later on you'll talk about ARDS. You guys know, have you guys talked about ARDS? No, right?
Miss Ortega, yeah.
Poor Ms. Ortega. I'm just kidding. But ARDS, guys, so it's a problem with the lungs. They have fluid, they're stiff, like all kinds of bad problems. You know, this is how we diagnose, this is how we treat problems, and then later on you guys will start doing like vents and start talking about all that cool stuff, okay? Questions? All right, guys, that's all the boring stuff that we have. Everything else should be easy. So here's an example of shunting. They call it shunting, right? It could be a silent, where both the lung is collapsed and then it's putting pressure on there, and both are down. So, and then if this patient, let's go through let's make up a case study. Patient, they have a, and don't look at this anymore. They have, look down or look away so you don't get the answer. Think it through. If they, let me backtrack. Patient is driving down the street on a motorcycle, on a motorcycle, and they hit a tree, right? And everything else is blank, and then there's one damn tree there, and that's what they hit. Okay, that's how it is. Trauma sucks. And they hit that tree, and initially they have atelectasis. Okay, what VQ mismatch would be?
Low.
Low. Okay. As the patient gets up, he's like, oh my God, he's like panicked. He has broken ribs, and those ribs are floating around, and he punctures a lung, okay? Now he has a thorax as well, right? And it becomes a tension pneumothorax, pneumohemothorax. Now, because it's a tension, what's the VQ? Silent, not high, remember it's silent, both of them are down, yeah? Okay, now, is this patient gonna be acidotic or alkalotic? What shift are they going to have? A right shift or a left shift?
Right.
A right shift. Does that make sense? All right. That's how I encourage you guys to kind of go through scenarios. Like, just make something up. A patient has asthma. What VQ and they have, an asthma exacerbation. What VQ mismatch would they have?
Low.
Okay. Initially, what acid-base balance would they be in? Alkalosis. Patient's not being treated, he's at home, he's not doing anything, he didn't go to the hospital, so then he slowly starts to not breathe and starts to get tired. And what acid-base balance would they be in? Acidosis. Okay? So if their SaO2 is now, SaO2 was initially 92, and we're making numbers up, okay? What would their PaO2 be now? Number, just throw a number up.
55.
55, 70, right? Because now, what acid-base balance did they shift to? To the what?
Left.
No, to
To the
the
right.
Acidosis, to the right, to the right. Okay, does that make sense? Yes.
For pneumonia, you said the
For what? I'm sorry.
pneumonia. You said the VQ was high.
Pneumonia, no.
It's low, right?
Yeah,
Okay.
yeah. Right? Because pneumonia is a ventilation problem or perfusion problem?
Ventilation.
Yeah. If you think about it, for perfusion, there's like two things that we can think of, right? Three maybe. Perfusion would be what? PE. Maybe a tension pneumo, right? Where both would go down. And then we said one more, maybe pulmonary hypertension. Yeah. Does that make sense, guys? Yeah, I hope so.
Pulmonary hypertension, like fluid in the lungs?
No, pulmonary hypertension is a state where the pulmonary artery is enlarged, the pressure is a lot higher. It could be related to CHF from the left side of the heart that's backing up. Yeah. Okay, the rest should be like, we should fly through this stuff, guys. PaO2, you guys all know this stuff. We talked about this. Okay, guys, this is old junk that I'm just gonna throw out the next semester, but just so you know. So you have nasal cannula, the max is 6, simple mask, non-rebreather. Yeah.
Are you gonna test this on this?
What? Okay, so no, right? But like if so yeah, maybe yeah. Now think about it. So if a patient has a non-rebreather on, and it's gonna be a trick question. Okay, I want you guys to think about it for a second. Patient has a non-rebreather on. Okay. Think before you answer. Okay. I'll tell you when to answer. Non-rebreather on. Okay. Nurses new grad. We won't mention what school. Not from RCC.
West Coast.
Not West Coast. Leave our West Coast people alone. They're all right. They're still nurses. Okay. So the new grad puts a non-rebreather on the patient and puts it on 2 liters. Okay, what acid-base balance would they probably be in? What do you guys think? We're making stuff up, but let's just talk it through. What do you guys think? I would think acidosis. Yeah, because 2 liters. What's the minimum you're supposed to have it on? Like 10, 6, 10, right? So if you're putting somebody on on one of these, you know, like right, you know. So what shift are they gonna have? A right or a left? A right shift. Okay. Pretty easy, guys. So go through case scenarios and you know, just talk it from the top all the way down, okay? Does that make sense? Maybe that last one didn't make sense, but you know. Okay, as far as what I'm gonna test you on these, no, just know that there's a minimum for at least like, you know, anytime you put a mask on the patient, there's gonna be a minimum. And I would say the minimum is what, like 6? The nasal cannula, what's the highest it goes? 6? That's it, guys. Okay, don't ever get caught putting a freaking mask on somebody and putting 2 liters on that mask. Right, not good. Let's see. You guys have all seen this. I'm a huge fan of the non-rebreather. You put it on and you just crank it up to like max, and just like, hopefully that helps. These are old. This won't be on the test, but these are little gadgets that you would put inside the mask to regulate what percentage of oxygen the patient would get. Precise oxygen. Usually that's only seen like in COPD patients, or maybe pediatric patients. In general, what's the amount of oxygen in the atmosphere? 21, 20 something, whatever, right? And the rest is like different gases and stuff. The rest should be super easy until we get to. You guys, poor baby. Anybody need a break? No? Okay, so this is old information, but 16,000 deaths per year occur from chest trauma. What do you guys think, what age population do you think, and what sex, male or female, do you think probably is affected mostly by chest trauma?
Young man.
Man. Okay. We don't know how to act supposedly. Okay.
Maybe they don't have.
What age?
Probably about
I'm
12,
guessing
12 to
like
20,
12.
12 to 23.
The exact numbers change as far as ages, okay? But the dudes in here. We're cool, man. We're past that age, okay? Okay, we're past that age, though.
Yeah.
We're looking at cancer now.
They already dropped. Ya cayeron.
So, usually, guys, and ladies, the chest trauma is usually a younger adult problem. It can happen to anybody, but usually you see a lot of motor vehicle accidents, motorcycle accidents, falls, stuff like that. And the problem is that anytime you have a chest trauma, not only, there's a lot of things that can happen. You could, let's say that motorcycle person coming in at 100 miles per hour, that sudden stop, that shearing and tearing inside. If I remember correctly, the heart is surrounded, it has ligaments and everything. It has, it's connected to the aorta and all kinds of connections. But one of the things that is often seen is a tear in the aortic arch. That heart just rips forward and it just tears and patients die. You go up to a patient, you feel their pulse, they're pulseless, what do? Start chest compressions, what are we doing? We're just helping them die, okay? I'm not saying don't try to help, but so chest trauma, and it usually occurs in that younger male, okay? Supposedly, males are more high risk individuals that just, no, somebody says stupid, but hey, the day I graduated, I had bandages around my arms because I flew off my motorcycle.
Oh my God.
But that's just unfortunately a thing, I guess. But usually, like I said, the age is the younger adult. I don't know up to what age, maybe like 30, but for sure like 17s to like 30. That's the biggest and the leading contributor to death in our younger adults, okay, specifically males. With ages, I'm sure, with the different age ranges, I'm sure you guys all know, like we have different things that take us down, and I think towards the end, it's suicide, it's cancer, younger folks, it's like maybe genetic disease or malformations or whatever. In between, in the 40s you have ACS, acute coronary syndrome, heart disease, stuff like that. But younger adult is usually the victims for chest trauma. And like I said, the problem with that chest trauma, let's say if you're driving a vehicle, you have a steering wheel, that sudden stop, that steering wheel to the chest, that car impacting you, that move to the side, or any of that stuff can cause a lot of problems, specifically chest trauma. We don't really go over head trauma much. You'll do that in N-22 because we start talking about like ICP pressures and stuff like that. But yeah, so when we have chest trauma, patients will come into the ER, we'll try to save them, we'll do anything we can. We go as far as cutting the patient from one side to the other, okay? And we if there's anything bleeding, we try to stop it. Usually people will die from hemorrhaging, from what else? Just the blunt force, just stuff ripping apart inside. So it's pretty ugly. This includes not only motor vehicle accidents, it includes stab wounds, gunshot wounds, all that stuff, okay? So it can be pretty ugly. And depending where you live, you might obviously have different types of traumas. Like, in San Bernardino, unfortunately, we did get a lot of gunshot wounds, a lot of stab wounds. And in general, we have a lot of accidents, Off the 395, we used to have a lot of vehicles go head on, just have head-on collisions. Any EMTs in here? EMTs? Were you guys EMTs for a while or no?
Yeah, I don't want to get one.
Okay. So then chest traumas, and then the other thing was falls. We had one of our RCC grads, one of my students. She was a nurse. She went out on a hike and she fell down the little embankment in the woods, and unfortunately she died. Okay. So we have falls, we have compression injuries from the acceleration, and then all of a sudden you come to a sudden stop, and all that compression forward. I don't remember they teach us the numbers, but I don't remember what it is. But I think, if I remember correctly, if you're doing 100 miles per hour, there's a word for it, but that sudden stop, increases the speed, if you will, of the accident by 4 times or something.
Yeah.
So I don't remember exact numbers, but yeah.
Just stay home and study. I'm not going out.
So they say if you skydive, it's not the dive that kills you.
It's the stop.
It's the hitting the ground.
Yeah.
That's not.
On that note, if you have a patient come into the hospital, what are some of the nursing interventions that we're going to, now we're switching back over to regular stuff like nursing interventions. What do you do? What are your priorities? If a chest trauma comes into the hospital, what are some of the things that we're going to do? We're going to assess, we're going to draw labs, specifically CBC, BMPs. We're going to draw lactates, see how bad it is. We're going to do, what about films? What kind of plain films or complex films are we going to get? Chest x-ray, what else? CT scans. If you don't know what the difference between a CT scan, I'll just tell you, and a chest x-ray. Chest x-ray, guys, is a picture. It's me right here, and this projector here is taking a picture. It takes all the hard stuff, which are the bones, and all the air stuff or the non-dense stuff, and it creates a picture. So the picture goes from black all the way to white. White being the bones, black being air. And I'll show you in just a little bit, but if you ever see complete like black, that's not good either. And we'll talk about it, why in just a second. So we're gonna do chest x-rays. It's gonna give us like a quick overall look of the chest to make sure that there's no trauma. If there is, we're gonna do something about it. We do a quick ultrasound of the heart and lungs, and we're looking for fluid. Okay, usually, yeah, we have fluid in our vasculature, but if we have like free fluid or free air, remember we talked about free air? We talked about free air, yeah?
Yeah.
Free air, free fluid, there's probably something happening. Free air means what?
Rupture.
Maybe rupture / perforation, and free fluid can mean the same thing as well. And so we're gonna do chest x-rays, EKGs. Why would we do, bless you, an EKG?
Rule out a stroke.
Yeah, so sometimes if that person hits hard enough, you know, you can have a bruise to the heart, a contusion. And so what we do is we do an EKG. We do an EKG and we're looking for cardiac changes. Sometimes you will have cardiac changes. Maybe a few days later, like 2, 3, 4 days later, your heart will get swollen, okay? And then you'll have ECG changes. So we initially get an ECG. We might run fluids. There's a whole like stack of things that we do as a nurse, okay? And so why? Because everything that's important aside from our head is located centrally. So here it says you can go into hypovolemia, hypoxemia, excuse me, I missed that. Hypoxemia, why? Well, if the lung is collapsed, if anything happens where you can't breathe, if you have like 3, 4 ribs broken on each side, you're not gonna be stable. Hypovolemia, any kind of bleeding inside. And then cardiac failure from cardiac tamponade. If you remember, cardiac tamponade is what?
Fluid.
The fluid
That pericardial sac will fill between the heart and the pericardium. That sac will fill, and it pretty much, if you have, think of the heart and then it's surrounded by a sac. If you have a little tear or whatever, and it's pumping blood into that sac, it's gonna fill and fill and fill. Eventually, that heart's gonna have a hard time filling because it's gonna be like as if it's being clamped down by something, right?
It's
Which
like-
is that?
It's like
that
the same
bag.
concept as a pneumothorax. For the heart though. 'Cause
Yeah,
it's like fluid.
kind of, yeah. Tension pneumo, yeah. It's same thing, like, yeah, it's just pushing down on it. So we can have those problems. So it can lead to everything from impaired ventilation, acute renal injury or acute renal failure. Why would we have acute renal failure with like upper chest trauma? Shunting, what we just talked about, that hypovolemic state. Later on, you guys will learn like the different stages of kidney problems, but if you don't have enough blood to the kidneys die real fast. And then hypovolemic shock, and then obviously death. A patient, if they were in a hypovolemic shock and cardiac respiratory shock and all these problems, what acid-base balance would they be in? Maybe what? Or maybe a mix, yeah. What way would they shift in their right? What way would they shift in their oxyhemoglobin dissociation curve? It would shift to the right. You know, all these things that we've been talking about. What would their PaO2 be if you can't breathe, you can't do anything? Give me a number.
60.
just so you know, the lower your PaO2, okay, the higher likelihood of you gonna need a ventilator, right? That breathing machine. Okay. If we were to put oxygen on a patient with a low VQ mismatch, so like for example a tension, like a pneumo, a regular pneumo, they have a low VQ. If you were to put that 10 liters of oxygen on them, on the non-rebreather, and you're pumping a bunch of air and they're like, would the oxygen help if you have a low VQ? No, because the atelectasis could be so bad that it's just not, you're not making contact, that oxygen is not diffusing in your system, so it doesn't matter, right? We have to take care of what's causing all the problems. And then this is where we start talking about your ABCs, right? You want to assess the airway, the neck veins. When we look at this and they say assess the airway, that's pretty obvious, right? We want to make sure that you don't have a deviated airway. What does deviation of the airway mean? Attention pneumo, okay? Deviation of the airway is a late sign. We could have circumoral cyanosis, that's another late sign. When you talk about neck veins distension, right? Why would you have bulging neck veins? Heart failure, maybe cardiac tamponade, right? What about difficulty breathing? We understand that. Chest symmetry is not symmetrical. Why? Maybe lung collapse. Why else? What did we talk about earlier?
The rib.
Broken ribs, a bunch of broken ribs. Okay. What else? Tracheal shifts. We talked about this. When we have exit and entrance wounds, impaled objects, obviously, depending on, we're not gonna get far, guys. Okay, depending on how or what kind of injury that patient had, you can have impaled objects. I'd show you pictures, but I don't have time. So some of the things that we want to use are the chest X-rays, CT scans, CBC, clotting studies, ABGs, all these things that you see up here. Of note, you guys probably already know, when we do a lactic acid, we put it on ice. Why do you think we put it on ice?
If it's warm, the germs would just go more.
Not the germs.
Oh.
The acid just keeps building.
Yeah. So remember, the hemoglobin inside, it's not, I don't know that I can say it's living, but your hemoglobin, once the cell starts breaking down, they start like dying, they start releasing its, hydrogen ions, whatever, and they start breaking apart. So your lactic acid is put on ice to slow that process down, okay? And then we send it off and we try to get an idea of what your lactic acidosis is. So that's why we put it on ice. Yes? That's a great question, and I do have pictures, I think, of them. But she asked, with bullet wounds, how do we get like the scans and stuff? What happens is, let me see. Oh, it sucks. I don't have time. Yeah. So what happens is, what would we use to see where the bullets are at, or the fragments?
CT.
So we would see a CT. We would use a X-ray first of all. Okay, if you have a bunch of fragments inside the body, it's gonna just fragment all over the place. Usually bullets are made out of some kind of metal alloy, lead or whatever, copper, and so that's gonna show up as what color in the X-ray? White. Or a CT scanner would also show us some of that stuff, and so we could see all the pieces. Sometimes when we have a gunshot wound that goes through and through, meaning the gunshot goes in or the wound goes in and it comes out, what we do to identify these on X-ray or on CT scan is we put a paper clip right at the entrance. So the round part of the paper clip, we open it, we tape it on that person, and when they go through the scan, we know, hey, that's that paper clip, to give us a point of reference of where it went in and where it came out. Okay, that's a good question. Going over these. And then, so here we get into the pneumothorax. We've talked about this in some good lengths, right? For some reason, the lung goes down, whether it's a gunshot wound, a chest impalement, anything. Motor vehicle accident, impact hard enough on your chest that lung's gonna collapse, what kind of VQ mismatch would that person have? High or low? Low. So if you put oxygen on this person, they may or they may not get oxygenated because of that VQ mismatch is all off. And if you look at the picture, if we allow that person to continue with that down lung with that atelectasis, you can have all kinds of complications, right? If it's an open wound to the air, if they keep breathing, you guys see this air is going to overcome the air that is in the lung, and eventually it's going to push the trachea to the side, and that again, that's a late sign, tracheal deviation, all bad. That's a medical emergency. Usually, guys, when we see an atelectasis that big, we're putting a chest tube in. Your book talks about needle aspiration, and it talks about chest tubes, right? I think I'm jumping ahead, but needle aspiration, guys, all it is like a little T of a needle, literally like a needle with a T. We go in and we allow this positive air to come out to allow the lung a little bit of room to breathe. They still need, after that needle aspiration, they still need a chest tube in there to help reinflate that lung, okay? And so being that this is all chest tube stuff, we would be open for chest tube questions on the exam, okay, for this stuff. No, but like management of chest tube. Yeah, the NP does that. The nurse practitioner, the physician does that, yeah. But we wouldn't put a chest tube in as a RN, at least in California, I don't think. Other types of pneumothorax, guys, we have spontaneous, we have open, and we have tension. So spontaneous, we have a certain group of people, usually they're Marfan syndrome patients. They're tall, I don't know, is lanky a bad word? Like slim, lanky looking, tall folks that they'll be walking around. It doesn't have to be super tall, but just like that real slim patient. All of a sudden they'll be walking around, shortness of breath. They'll have a spontaneous pneumo. And like the pathophysiology behind that, I'll have you guys look it up. We'll just keep going, but just know that you can have a spontaneous. There's an open one, is exactly what we're talking about. Gunshot wounds, knife wounds, etc. And then there's the tension where you have, maybe after CPR, you have that chest trauma, that blunt chest trauma that just creates a lot of pressure inside and creates that tension pneumo. Signs and symptoms of pneumo, obviously chest pain, air hunger, respiratory distress, tachycardia, any systemic signs that you can think of not being able to breathe. Has anyone ever got the wind knocked out of them? They say that's a little mini pneumo, okay, and we're able to resolve those. But when you have those huge pneumos, we're not able to naturally resolve those. We need interventions. When you guys go through these, be able to talk about each one of these. Why do they have chest pain? Why do they have tachycardia? Why hypotension, etc. Okay. Assessment. So if you have a pneumo, guys, on the side where that lung is down, obviously you're not going to hear any air moving. So you would hear maybe silence. You would hear nothing. Hyporesonant. Yeah. They might have decreased expansion of the lung when they breathe in, when they breathe out, just because there's nothing pushing that lung out, or right? Let's see. With a gunshot wound, that a hole in your chest, you might have what they call a sucking chest wound, and every time you take a deep breath, it'll sound like a little bit of wet gurgling, okay? Because that as you take a deep breath, you're also pulling air inside, and you're pushing more air. And that air eventually could become a tension pneumo. You would have sharp chest pain, tachycardia, and everything else that goes with this. And again, tracheal deviation to the unaffected side with that tension pneumo. Immediately, we're going to have chest x-rays, ABGs, everything that we've been talking about. And again, continuous EKG, because even though the accident happened now, sometimes we get inflammation later on. So tomorrow, accident happened today, tomorrow you might have signs of cardiac tamponade or pericardial effusion or different problems that happen post trauma to the heart. You might have electrolyte imbalances because of whole acid-base imbalance. And in treatment, again, the immediate treatment for pneumothorax It says immediate needle decompression. So again, it's that needle, we get the air out, and sometimes we've done it with 18 gauge IVs in the hospital, and it's just a okay, and then from there what we do is we go right into a chest tube. Okay. This second and fifth intercostal space stuff, you don't have to know. It's not something that we're gonna do anything with. This used to be a decent picture, but I don't know if you guys can read it on your PowerPoint. It's just dyspnea, anxiety, tachycardia. It's everything that we've been going over in the last 2 slides. Just make sure that you understand why would you have this, why would you have that, and what am I gonna do about it as a nurse. Diagnosed by chest x-ray, ABGs. With a patient that has a massive pneumo, that's what's represented here, this huge pneumo. What would the PaO2 on the ABG show? Give me a number.
On which one? On what?
60. PaO2 on a massive pneumothorax. Patient can't breathe, PaO2 is gonna go down, right? What VQ mismatch would they have?
No.
Low. Does that make sense? Yep. Usually, by the time they get to us, they have the appropriate dressing over that. It would be an occlusive dressing over that hole. If it's a homie drop off, and I'm not kidding with this, what we would do is, you guys know what homie drop off is? The friends just came by. Take off. If it's that kind of instance, what we would do is we would put dressing over the chest wound. You would put something plastic or something of that nature, non-porous, over the holes to cover that hole. And usually, if you don't understand what I'm gonna say, it's okay. Like, don't even worry about it. Ask me after. But usually, what we would do is let's say for a gunshot wound, we put something like a credit card over it. We would tape 3 sides. We would leave the bottom open, because what happens is when they breathe in, it sucks up against the chest and it doesn't allow air in. But if they cough out, that air is able to come out from the bottom, so we wouldn't create a tension. If that didn't make sense, don't worry about it. And if you want to know what I'm talking about, just come after. We'll talk about it. It won't be on the test, but just so you know. Actually, I take that back. Easy question, okay? If I remember to write that, easy question, right? How many sides of the chest would, or of that occlusive dressing would we tape?
3.
Okay, so we wanna, once they get that chest tube in, we're gonna put a chest tube in with the idea of getting that lung fully expanded. How are we gonna know if that lung is fully expanded?
The chest right.
Chest x-ray, okay? We're gonna do chest x-ray, we're gonna insert it, we're gonna do chest x-ray after. We're gonna be looking at the pneumo, ensure that we're in the right spot. And then every day, we're gonna do a chest x-ray to ensure that that pneumo is resolving and it's not getting any bigger. And so I'm gonna show you pneumo thorax x-ray. So just so you know, let's see. Remember I told you, hopefully this pulls up. Okay, so this is like a horrible, horrible pneumo. This is probably a tension here. But can you let me see what it looks like on your screen.
Oh, yeah.
Okay, see on the left side, see these little lines here? Like, this is black.
Yeah.
Okay, see on the left side, you got these little lines and stuff? That's lung. That's normal, okay? Because we have vasculature inside. When you see something that is like black, that means that that lung is collapsed. This is a severe case, and you guys see that? This is supposed to be the lung up, and this is like lung down. Okay, so this might be or this is probably somebody that did the like animation or whatever, but this would be this would be like right after the trauma. If you notice that lung, this represents, I don't know that the lung can get this bad, but this represents the lung just completely collapsed. And then this is after resolve, but I'm not a huge fan of the resolve picture. Let me see if we can find another one. This would not, let's see. Okay, you guys see the difference? So this here, oh man, it's made it smaller. Oh, here we go. No, it's made it smaller. This one on the left, I think it might be the same picture. This one on the left, the lung is up, and this complete black area, the lung is down. So the chest tube would be inside on the right, okay? And then as the pneumo resolves, we would see more and more of these funky little curly, like, these lines increase and increase until that patient's back to normal. I don't believe that's a normal lung, but. Because, how can you tell if it's blood or air?
No,
Because
some.
air would be what color? Black. And then so normally if we see like fluid or blood in there, it would be like solid, right? I'm gonna show you one more and then we're gonna move on. That's a normal lung, and then here's a collapsed lung. So you guys see the difference, right? Okay, so we're gonna monitor chest tube drainage. We're gonna monitor for subacute emphysema. So with the chest tube drainage, guys, you wanna make sure that your trends are always nice and stable and easy, okay? Usually, there's always a, but what about this time? But usually, when a patient dies, guys, it's not all of a sudden. When something happens, if it's all of a sudden, it's bad, okay? Usually people they're not walking all of a sudden, bam! If that happens, it's probably because, something happened and they died. With with these chest tubes, it's the same thing. Usually as the chest tube, as the drainage or as the pneumo resolves, it's nice and slow. So if all of a sudden, like let's say a patient was, draining 50 mLs an hour for the last 5 hours, like continuous 50 mLs, and it's bloody and it's sanguinous, but nice and easy drainage, not too bad. It's still a lot, but not too bad. And then all of a sudden it's 0, there's a problem, right? Something may have clotted inside and, there's a problem. What would be the complications if we had a chest tube in a patient and they clotted off inside? Like let's say after trauma and that chest tube was placed around the heart. What could be a complication if they stop draining blood?
Like a thrombus?
The what?
A thrombus will
Thrombus, but what else?
Hemothorax?
Let me ask my question again, because I know sometimes I'm thinking I said the right thing, but I'm talking in Spanish. And so if a patient is, let's say they're involved in a motor vehicle accident, they have trauma, and they're bleeding inside. So they have a hemopneumo or a hemothorax, okay? They're bleeding inside around the pericardium area. We go in, we put a chest tube, okay, and that patient's been, their output's been about stable at 40 an hour for about 3 hours, okay? If all of a sudden it goes to 0, okay, you don't see any more blood coming out, it goes to 0, what could be the complication of that? What could that be indicative of?
Blockage?
A clot, a blockage, and what can be the complication of that?
The heart will
Cardiac tamponade. Does that make sense? Like something inside is happening, okay? Not so much a PE. Maybe a PE, yeah. Depending on what's happening, what's causing, yeah. So,
pressure issue.
say it one more time. Just on the location, yeah. So a hemothorax is exactly what we've been talking about. It's accumulation of blood in that chest cavity. It could be massive, guys. It could be 1.5 liters. It could be 2 liters. And usually a result of a penetrating trauma. So a lot of times, think about it, if that patient gets stabbed and it nicks the pericardium, but they're okay, and then, patient gets sent to the unit, and maybe the following day the patient gets up, they start coughing and it tears that pericardium, you could have that hemothorax, all of a sudden. So even though we are, like, let's say 1 day after trauma, you can still have problems that result from the original trauma after, okay? So we're not out of the woods just yet, until maybe like a day or 2 or whatnot. Hemothorax treatment, again, it's that chest tube. We have to allow that blood to come out. Hopefully it'll stop or slow down, resolve on its own, but we can't let all that big giant amount of blood in there. If we need to, there's options to auto-transfuse. Sometimes, a lot of times, if you have a hemothorax inside, they probably require intubation. They probably need treatment as far as taking them to OR and such. And then remember, part of our trauma workup, remember what's inside, the great vessels, right? The aortic arch, you have the subclavian, pulmonary vessels. You can have problems from anything inside, okay? So trauma, no good. Thoracotomy, what's a thoracotomy?
Remove.
You open the thoracic area. Guys, it's kind of cool as a nurse. I haven't been telling stories, right? Make you laugh. But as a nurse, I've had my hand inside a patient and I've actually pumped their heart and like I've put epinephrine in that heart. And as soon as I did, that heart was like, ooh, it was like, damn. Putting a bunch of crack in that dude's heart. And, you know, we took him to OR. We split that patient in half. We like literally split him in half. We took all the guts out. We moved them to the side, like, you know, and like started looking for bleeds. The lungs are kind of cool. They look just like they do in the movie. It's like, you know, the lungs come out and they're just like little bags, like pink, pretty little bags. And then when we went inside that patient, when we took everything out, it was the weirdest thing. The cavity inside in the human, it's literally a cavity. Have you guys? Well, you guys remember when you empty out a pumpkin, how it's a cavity? We're literally a cavity like that. The inside looked like I don't remember beef or pork ribs, but they look like ribs, like exactly like that. It's a cavity. It's pretty gnarly. I got to help take out a kidney.
Did you found the bleed?
He died. Yeah. Oh man.
No,
I mean,
seriously.
he died.
Right?
Yeah.
We
But-
dissected him, but he didn't survive.
Like, oh, you know.
Turned into a science.
No,
class.
Anyways, he died. Chest tube. Remember the chest tube? That it's a self-contained system. I don't care on the test. I don't care about the difference between the wet or the dry. Just know how to remember the wet and the dry system.
Yeah.
I just know what your nursing interventions are for that chest tube. Okay. If you want to, and I recommend it, look at the chest tube learning module, and that's it as far as the chest tube goes. Remember that chest tube is when you change it out, that whole thing gets dumped in the trash, and then we just take out the box, if you will, of the chest tube. Because the chest tube is the actual tube, okay? What do we call the box? The what? Not the chamber. What do we call that box? Do you guys remember?
The seal system?
I'm having a blank right now. I'll remember, but it's the. Oh my god! I worked on it for years. I can't think right now. Anyways, moving on. But just know your nursing interventions for the whole chest tube system. I can't think. Anyways.
Yeah. It says chambers.
This is not something you're responsible for, but just so you know, what we do is we go in, we make a little slit, a fifth intercostal, and then we go in with Kelly clamps, we open it, and then we stick our finger in there. And like literally, like it feels like a pop. You guys ever done ribs? Anybody ever mess with ribs? You know that layer, you push it in, like pops? Same thing. And it hurts like crazy. So they say, they scream. We give them meds, but, and then, just so you know, nursing in general does not remove chest tubes, but depending on the unit you're in, you can remove a chest tube. So we used to remove chest tubes. All it was, pleurovac, that's what it's called, the pleurovac, thank you. The chest tube, the box pleurovac, that's what we refer to the little box. The chest tube, or I'm sorry, when you pull the chest tube out, depending where it's at, if it was a chest tube for a pneumo, remember that when you pull it out, it's a hole, right? Straight in. So one of the things that we had to do is we used to have that occlusive dressing. As a nurse, this is nursing intervention stuff, that occlusive dressing. And so we would, put the occlusive dressing down with a bunch of gauze over it. And then as we pull down, we put pressure on that occlusive dressing because we don't want to cause a pneumo. Immediately, and this is all testable stuff, guys, immediately after, what do you think we would want as far as like studies or whatever?
X-ray.
An X-ray. An X-ray, we're monitoring the patient, excuse me, vital signs, their O2 status, make sure that they're not decompensating because we gave them a pneumo, okay? And then remember, like your basics, the lung sounds will be clear, equal bilaterally. If they're not equal, let's say if they're not equal up top, that could be indicative of a pneumo. Maybe the lung went down. And then adequate pain control. Anytime, remember this, anytime you deal with lungs and all that area, you know, lungs and ribs and all that, there's a lot of nerve or a lot of intervention in there. So a lot of nerve a lot of nerve endings in there. Sorry, what is that equal to? As what is that? How does that affect the patient? Holy bananas! Pain. Okay, pain. Almost pain. Okay, so anytime you deal with broken ribs, anything in there, pain, pain, pain. A lot of times these patients will come back on a PCA. What's a PCA?
Patient controlled analgesia.
Okay, remember the lockout, the basal, all that stuff. You review that. But yeah, lots of pain. Okay. Fractured ribs. One of the big problems is fractured ribs, okay? So if you think about our thoracic cavity, our ribs it's our cage, right? So if you have, you know, multiple ribs, like let's say 4 or 5 ribs broken on one side, let's just say one side, when you take a deep breath, you're gonna be breathing like how I walk sometimes after the gym, like, you know? It's gonna be so bad that the patient's gonna take a breath, one side's gonna go up, one side's gonna go down. So when you have those floating ribs, you're at risk for puncturing a lung, okay? Just so you know, if you don't break enough ribs, let's say you break 2-3 ribs, what do we do for you? We in the medical field, what do we do for the patient that's broken? Huh? What do we do? Pain meds, what do we do? Nothing.
Oh.
Nothing. Pretty much like, hey, splint, you know, make sure that you're not, you know, twisting or getting all wild or anything, but there's nothing that we do. Unless you have instability in that thoracic cavity, then we would take you down to OR, and that's when you have like the different braces, maybe a TLS brace, maybe like different, you know, tools to keep you stable. But otherwise, a few broken ribs, you just have to go get through it with pain medication. A lot of pain, depending on how bad it is. So let's think about this for a second. If the patient has a big trauma and they broke ribs, they went out, you know, skiing or whatnot, and they break their ribs, they come back after OR, and you notice their O2 sat is 89. I don't want you guys to answer, okay? Just think about it. 89. So the patient's 89 and broken ribs. You know it's painful. When you assess the patient, right, you see him like this. Okay? You know that if you give morphine, you're going to make them desat. Okay? Why are they not setting higher? Okay, so who would give morphine? Raise your hand. Who would not give morphine? Who doesn't know? That's a real crappy question.
Give them O2. I'd give them my blessing.
I'll give them one.
What time have we done that? 9?
10:05.
10:05, thank you. All right, so nursing interventions with rib fractures.
Wait, what's the answer?
What's the answer?
Can you please tell us?
No!
Why?
For what?
It was on the test.
For the
It was on the
exam.
test.
What are the options then?
I don't remember.
Please tell us.
What's causing the pain?
The fracture.
The fracture, not nothing.
The patient. So if you're not breathing, let's remove. Okay. So if the patient had cardiothoracic surgery right down the middle, right? They did thoracotomy. They open them up. They close them up. They wake up and everything, and they can't breathe. Right now, had like, I don't know. I'll give you an example. like a big abscess, and every time that you took a breath, you know, or whatever, it hurt. If you had pain medications, you can breathe, right? So I would say it's not a respiratory kind of problem. It's more related to that pain. Does that make sense? So look at what's given to you. Look at your patient. Assess your patient. Don't be saying, oh, Mr. Ortega always says give him pain meds at setting, you know, 80 nothing. Think about what's happening. Okay? Does that make sense? Okay, so it would be immediately post-op, or patient has like a 10 out of 30 or 30 out of 10 pain and blah, blah. So think about what's happening. So here, monitor for respiratory distress. You listen to their lungs and they're fine, they're just not breathing, they're shallow breathing. What number respiration rate would they have for shallow breathing?
Like 8.
Yeah, like 8. Like, you know, just, right? Instruct the patient to splint with a pillow. What is that going to do? It's going to put that counter pressure so that they can actually take a deep breath. Flail chest, guys. That's when, let me see if I have a picture. That's when that chest, I don't know if you guys can see, this chest here is supposed to be higher and this is lower. That flail chest occurs when you have enough broken ribs on one side. Here it says 2 broken ribs in 2 or more places, so you have different fractures where you take a deep breath and the ribs are kind of folding in on themselves. Flail chest, a lot of times this is a medical emergency for reasons that patient can puncture their lungs or they're not breathing. If that's the case, if we have like the paradoxical breathing, we might take them up to OR. Can result in severe respiratory distress, and yeah, you would need, a lot of times you would need an ET tube, meaning mechanical ventilation, endotracheal tube, and chest tube. With an endotracheal tube, mechanical breathing, what we're thinking is we're gonna force you to breathe in and out. That patient's gonna be able to, you know, survive a little, not survive, but maintain until we take them to OR and maybe do a intervention. Normally what they do, guys, is they'll do plates for broken ribs. Excuse me. It's not like we can fuse the ribs back together. You just put like plates and hold them all together and call it a day. You had a question? Surgery, she's asked if the ribs are broken bad enough. Yeah, so if they're broken bad enough where you have that flail chest, they'll put like, so these are the ribs and they're broken like this. Maybe they'll put a plate on there so that the ribs are together, if you will. And then over time they'll fuse back to normal, or not back to normal, but they'll fuse together and, you know, that's it. Yes. So after OR, they're gonna come back, they're gonna have a lot of pain. You're gonna want them to use that instead of spirometer. They're probably gonna fight you on that, but these are your nursing interventions that have to be done in order for that patient to, you know, get better quickly versus not as quick, okay? Pain meds, remember we talked about them coming back on PCAs, stuff like that, yeah. Paradoxical respiration. So severe pain in the chest, cyanosis, dyspnea, everything that we've been talking about. And we saw that. So for these patients, you want to place them in that high Fowler's position. You want to give them, obviously, supplemental oxygen. If the oxygen is high enough, you want to make it humidified, warm when you can. And then just monitor for respiratory distress, monitor for that decline. You guys aren't talking about PEEP yet, but you know, they might need a little bit of PEEP. Maintain bed rest. Yeah. Encourage patient to use the IS, cough, deep breathe.
Wait, when do you want to like start ambulation, like early?
Depends on how bad that the rib fractures are. After surgery, once that thing is fused, I don't know how fast they get them out of bed, but I would guess it's probably pretty quick. Yeah. Remember that generally, short of being hemodynamically unstable, we want to get people out of bed post-op, you know, as long as it's not anything crazy. Like if you had a patient that's 500 pounds and has a big old wound that's known to dehisce, you know, obviously, you know, you don't want to jump too fast, but normally we want to get them out of bed and moving. And let's see, how much lung cancer stuff do we have?
Oh my gosh.
We're gonna leave lung cancer for the next lecture, okay, guys? Penetrating chest trauma, everything that we've been talking about. This one actually includes diaphragm. Remember that if you have a rupture in the diaphragm, that's another critical part that we need to breathe in and out. That's that muscle that helps us breathe. And then I think everything else we talked about, the lung, the pleura, most common falls, we talked about this. Okay, so in my experience, it's been you know, there's a big argument around gun people. I don't like guns, they're bad, they kill people. I don't own any guns. So gun people will usually talk about you know, what's better to carry. You know, a 22, and just so you know, 22, these refer to the size of the bullet. 22 is a tiny little bullet, a 45 is a big old fat bullet. And what it basically comes down to, in my experience, is two things: your luck and what kind of bullet they use. So I have a picture I'll show you guys, but here I think I put down the hollow point bullets versus solid point bullets. Let me show you here real quick. Oops,
We have to know the.
I want to show you.
Oh, it's fine.
Yeah. When I see a picture.
So, okay, just so you know, we won't get into the specs, right? But this is a round nose bullet, and this would be a hollow point bullet. The middle is hollow. The idea here is that a lot of times we use these, or those gun people use these for training, like paper targets, whatever. These are generally used, the hollow point bullets are generally used to kill animals or people. And so we kill lots of animals or people. She gasped, so I was like, okay, so the hollow point bullets, what happens, well, let me backtrack. The round nose bullets, what happens is those bullets will go in, and if there's nothing critical, a lot of times they come out. So it's not, I mean, it's a big deal, but it's not too big of a deal if it didn't hit anything. If it hit a bone, you know, it's gonna cause fractures or whatnot. But, and generally, guys, when a patient is larger in size, that cushion actually helps. We've had a lot of patients that get stab wounds and, you know, nothing happened. Skinny guy gets a stab wound and or a pinprick and he falls over and dies, right? So with a round nose bullet, guys, the chances of killing something, it depends if that person had bad luck and something critical was hit, you know. But if it went through the lung and out, not bad. Now, when you hit somebody with a hollow point bullet, which is this one, what happens is these are designed to expand and mushroom, if you will, on impact. So that bullet goes in and it hits and it expands and it goes backwards. It turns into a little ninja star. You can't see it very well. Actually, this picture shows you a lot better. It turns into a little ninja star, and it does a lot of things. One of the things, see these? It goes backwards, and it like just creates a little ninja star inside. Some of the damage that happens is some of these petals is what they're called. They rip apart and they keep going. They travel inside the person, and that can cause like little mini shrapnel, if you will, and just cut up the person inside. The other thing is these bullets will tumble. When that hollow or when that round nose bullet goes through, it goes through and through. All that energy does not dissipate inside the patient. It just goes right through. When a person is hit with these hollow point bullets, all that energy is this thing stopped working now. All that energy is placed inside that person, and so you have a energy of that shock, that all that, like imagine just a big giant punch inside your internal organs, and all that energy is dissipated inside that person. So that's the big problem. So it's a multitude of problems. You have the person that got a bunch of shrapnel inside, a bunch of cuts and bleeds and stuff inside, with a bunch of petals going all over the place, and you had all that full energy of a gunshot wound, versus that round nose bullet might go through and through, no big deal. These bullets are the ones where you guys may have heard where the person gets hit, tiny little hole in the front and big gaping wound in the back. In trauma, what we would see pretty often is that person would get shot. We had a couple that got shot with one of those, what they call the AR-15s, one of those little machine gun looking things. And one person got, they were the same bullets, one person got shot and that mushroom didn't expand inside of them, so the bullet went right out. The other person got shot, both of them in the leg. The other person got shot and it blew out her, I don't remember who got it, the woman or the man, but her gluteus maximus got blown out, like everything, like all of this was just blown out. And so it just depends on your luck. So what bullet kills, it depends. If that 22, that tiny little bullet, if that 22 was a hollow point, what it hit, versus was it a, you know, a bigger bullet, a hollow point, what did it hit, okay? The point of this was for you guys to understand that it's part of that trauma. What kind of injuries are you looking at inside the body? You're looking at that shock injury, those cuts, you know, depending on what they hit, the different kinds of bleeds. And so that's a lot of times what, you know, kills a person is that hollow point bullet. Most of the time when we have gunshots out in the street, it's usually the round nose bullets, okay? The hollow points are obviously more expensive. It's the round nose bullets, and you know, we do see those hollow points come through, and when they come through, they put somebody down quick.
They're illegal.
Anywhere. And what's sad, guys, is now this happens anywhere. This is my homie. I'm just kidding. Just talking crap. I wish I could show you guys my pictures. I have a knife coming out of a lady.
Playing darts.
Yeah. This is another person. He fell on the knife backwards. His wife was accidentally cutting him. So here the trauma, if you look at it, it looks like it's right in the middle. So to add, you know, more injury, if that person hit the spinal column, now you have another level of injury depending on where that person was hit. Again, if it was in the lung area, thoracic area, lung, you're looking at, you know, a penetrating open wound that would have to get a chest tube and all that stuff. So actually that was it. So the only thing we're not going to go over, guys, is the lung cancer. That I will leave for the last lecture, MCI. It'll be like the usual cancer stuff, nothing crazy. Questions? Yeah.
Just like on that note, so because this exam is like May 1st, so will lung cancer not be on that?
It will not.
Okay, because MCI isn't until May 15th.
Yeah, and that exam is not until June, I think.
Yeah, June 5th.
Yeah. So do not look at the lung cancer, guys. Cool? Cool. All right, guys, good luck. And